It is my job to welcome you to the session 6 in Hall B. Our topic is bone tumor, an always challenging topic in MSK imaging. Fortunately, we have four experienced speakers. Let me introduce the first speaker, Dr. Notaya Patama Paspong, Associate Professor of Radiology from Chiang Mai University. She was the former AMS secretary, and her topic today is benign, do not touch bone lesion. Please, Dr. Nataya, the time is yours.
Hi, my name is Dr. Nataya from Chiang Mai University, and it's my pleasure today to share with you the benign do not touch bone lesion. And I picked this topic because they encounter with this lesion more often because we do CT and MRI even more. And currently, there are guidelines to categorize this bone lesion into 4 categories, and some of them we can leave it alone because it's typically benign lesion. The example of these lesions are fibrous dysplasia and cartilaginous tumor as well as inostosis. So in this talk, I will highlight you some lesions that are has characteristic features and has some recommendation. I will focus on fibrous dysplasia, cartilaginous tumor, as well as looking at bone metastasis mimicker and focus on inostosis. Let's start with this case. This is a man who presents with retroperitoneal liposarcoma, and MRI was performed to look at the tumor. But we found lesion in his right femur, and the lesion has low signal intensity on T1, high on T2, and enhanced in the post-contrast study, and it can be interpreted as metastasis. But anyway, he has his CT scan done, and this show fibrous matrix as well as sclerotic rim typical for fibrous dysplasia. Another lesion, the man came for investigation of esophageal cancer, and we found multiple uptake in pelvic bones, femurs, and tibia. And we have corresponding CT scan that show multiple osteolytic lesion, typical gallgrass matrix, as well as has sclerotic border, typical for fibrous dysplasia as well. Another lady who came for physical checkup and chest radiograph revealed a lung lesion, or it can be chest wall lesion. And CT scan was performed, and she underwent rib resection because of some cortical breaking, and this turned out to be fibrous dysplasia. Another lesion, the lady came for evaluation for a hip pain due to avascular necrosis, but we found this lesion on MRI. And on MRI, that heterogeneous lesion is a sclerotic, osteolytic lesion with sclerotic border that has faint gallgrass appearance and typical for fibrous dysplasia as well. So fibrous dysplasia is the developmental disorder that have fibroosseous tissue replacing normal bone. It's a mutation that mesenchymal cell cannot maturation to mature osteoblasts or adipocytes or bone marrow. It's common in craniofacial bone, ribs, and long bone. Most of them present as a single lesion. This is a histological findings of fibrous dysplasia that have fibrous tissue and have bone tubercula. In alphabet soup pattern, this is a woven bone. But in fibrous dysplasia, you also can have aneurysmal bone cyst. It's a cystic-like lesion that present in older lesion. This means patients with old age gonna have this more often. It has hemorrhage and cystic change inside. It even can have condylar metaplasia. So these findings turn out to cause heterogeneity on MRI. Typical findings for radiograph, it can show endosteal scalloping, expansite cortical lesion, and it can be completely lucent or sclerotic. If it has internal tuberculation, it will look like bubbly cystic appearance with bone expansion. For CT scan, they can have bony expansion and internal tuberculation that may look bubbly cystic appearance. CT attenuation can be vary from 60 to 140, but gallgrass pattern usually over 100 Hounsfield units. It can also have heterogeneous enhancement. For MRI, the pattern can be greatly variable because of they can have fibrous and cystic appearance. It's usually hypointense on T1, have low signal intensity on T2 because they have tubercular bone, but they can have cystic change within the lesion. This is the pattern of fibrotic dysplasia that has lytic lesion with sclerotic border, intermediate to low signal on T1, hypo signal with cystic change on T2, and it has enhancement in the post-contrast study. Cortical destruction doesn't mean it's gonna be malignant transformation, and current systematic review show that there's no characteristic MR signal intensity to predict malignant transformation. And malignant transformation has been reported as high as 2.5, and in systematic review, that the cases are proven by biopsy. The malignant transformation rate is as high as 9%, which can imply that the lesion with atypical pattern or complicated lesions, such as lesion with cavity fracture, gonna have high proportion of malignant transformation. Let's move to cartilaginous lesion. This is the lady that has presented with soft tissue tumor on her right thigh, but she has another lesion on her left thigh. And when we do CT scan, it turned out to be typical for cartilaginous tumor, which is enchondroma. We found enchondroma or cartilaginous tumor more often because it commonly occurs in knee and shoulder, where we do more images for any cause of pain. The prevalence of enchondroma is roughly about 1 to 3%, and knee is the most common location. This is an example of the man who presented with knee injury, and MRI was performed, and we found the small cartilaginous tumor. Another lesion that shows ring and arch appearance on radiograph, and MRI show the rotator cuff tear as well as this cartilaginous lesion. For this lady, she has shoulder pain and found cartilaginous tumor, but the lesion approached the cortex, and because we cannot explain the cause of pain in this patient, biopsy was performed and turned out to be low-grade chondrosarcoma. Cartilaginous tumor will have characteristic pattern. It has intermediate signal on T1, has lobulated high signal on T2, and has lobular enhancement in the post-contrast study. It is easy to call this chondrosarcoma. If it has large size over 5 cm, it has endosteal scalloping, it has cortical destruction or periosteal reaction as well as peritumoral edema and soft tissue mass. But the lesion will be very difficult to distinguish enchondroma from low-grade chondrosarcoma. And right now we call it a typical cartilaginous tumor, both for pathology and imaging finding, like in this case that turned out to be low-grade chondrosarcoma. Because of this, we have guidelines that recommend how to deal with this cartilaginous lesion. They are the NIST guideline, Birmingham guideline, and modified Birmingham guideline, particularly applied to fibular region lesion. For the NIST guideline, is used in the lesion outside spine and head and neck, and applied for patients aged over 18 years. Birmingham guideline looking at tumor of knee and shoulder where we can have cartilaginous lesion in proximal humerus and knee. And fibular lesion, we have modified from Birmingham for humerus and knee. That's because fibula has small transverse diameter. So endosteal scalloping may be look more aggressive than it's supposed to be. When we look at the NIST guideline, the big picture of this guideline look at the lesion that's supposed to send patient to sarcoma center when the lesion size over 5 cm. It have aggressive pattern which have cortical involvement, either cortical destruction or deep remodeling, or has bone expansion or increased size over 6 mm within 1 year. From this guideline, the lesion that's less than 2 cm in size, no cortical contact, no surrounding bone marrow, edema on MRI, do not need any further investigation or do not need follow-up study. When we look at Birmingham guideline, the management of this will categorize patient to the patient that may need to refer to sarcoma center or do follow-up in 1 or 3 year interval. The lesion size over 4 cm, endosteal scalloping over 10% of the circumference, or has aggressive features such as cortical thickening, cortical destruction of soft tissue mass, or lesion that increase size over 1 cm will need special care. The size 4 cm less than the NIST guideline. This because to avoid discrepancy or a little bit different of measurement during the follow-up or between the radiologists. And for the guideline that modified for fibular lesion, because fibula tend to have more endosteal scalloping, so the interval of follow-up can be not as often as the lesion in tibia, and is integrate symptom in the algorithm. This is how we call endosteal, how we quantify endosteal scalloping. This is 10% scalloping, endosteal scalloping, which is roughly about 36 degrees. And this is an example of patient with enchondroma with limited endosteal scalloping and more extensive lesion that turned out to be a typical cartilaginous tumor. And this is how Birmingham guideline look like, and this is how we integrated the size criteria, the extension of endosteal scalloping, the change during MRI follow-up, and this categorize patient into the patient that require monitoring in 1 year or in 3 years, and categorize some patient to immediately refer to cancer center. We move forward to osteoblastic lesion, and this is example of typical enostosis that has dense osteoblastic lesion within the pelvic bone with spiculated border. And spiculated border is from the blending between the border of lesion and surrounding trabecular bone that will present as a thorny border within bone trabecula. Is the focus of cortical bone in calcareous bone and commonly found in spine and pelvis, and as well as epiphysis and metaphysis of long bone. The size usually less than 2 cm. The lesion is has low signal intensity on T1 or T2 weighted images. And if we found it on CT scan can have CT attenuation that help you distinguish osteoblastic metastasis from this enostosis. They're a little bit different in cutoff value among the study, but the most common one that we currently use is we use CT attenuation more than 885 and maximal CT attenuation over 1060 Hallfield unit. It will have rather high sensitivity and specificity to call this inostosis. However, this attenuation value has applied well for untreated lesion, but with treated lesion, the accuracy can be dropped from 90 to 80% when we use mean CT attenuation. And if we use maximal CT attenuation, the accuracy can drop from 80% to 70%. And when we apply this on PET-CT scan, we have to adjust the threshold a little bit. The appropriate cutoff point turned out to be roughly about 800 Hallfield units, and is supposed to interpret it with SUV value as well. Anyway, for treated lesion, the accuracy will be dropped because CT attenuation tend to be increased and PET usually decrease uptake. This cutoff value also have limitation. In a setting of biopsy-proven case, in this study, the accuracy dropped to 60%, both for mean CT attenuation and maximal CT attenuation value. But from this study, they cannot find the appropriate new cutoff point. And when we look at their false positive case, which are benign lesion, majority of this case turn out to be the non-specific benign histology, which is mean that there's a lot more osteoblastic lesion that is not inostosis and cannot even be named by pathological findings. And keep in mind that some inostosis can be look atypical. This is giant inostosis, the size over 2 centimeters, and it can increase uptake in bone scan. It can have surrounding T2 hyperintense halo, and it can grow over time. When it grows over 25% in 6 months or more than 50% in 1 year, that will be considered for biopsy. This is example of growing inostosis that grow over 12 years of follow-up. And this is an example of typical lesion with speculated border, low signal intensity on both T1 and T2 weighted image, and show a little bit of edema around the lesion. Because of this difficulty, their effort to use radiomic model to differentiating bone island or inostosis from osteoblastic metastasis. The benefit of using radiomic model is that it can have quantified analysis of heterogeneity of the signal intensity of the density in the lesion, as well as doing the measurement of CT attenuation for entire volume of the lesion. This is a capability that human being cannot perform. And please keep in mind that in some setting and some cancer, we may have other mimicker. This patient has lung cancer that has superior vena cava obstruction, and he also has osteoblastic lesion in the thoracic spine. But this osteoblastic lesion is not present in the pre-contact study. This is the effect of vertebral venous congestion. That's because we have obstruction of thoracic central venous system and have reflux to paravertebral venous plexus. The pattern of enhancement can be polygonal or nodular patterns, and we can have presence of collateral venous pathway. It commonly occurs in lower C and extending to thoracic spine and can reach T2 level for the upper lumbar spine. It also can involve the surrounding bones such as sternum and scapula because we also can have collateral venous pathway. So in conclusion, I show you more of CT scan and MRI that we can see incidentally detected bone lesion. I review you the fibrous dysplasia that have variable features on MRI and cartilaginous tumor that have several guidelines to dealing with this lesion. We have osteoblastic lesion that show you how we use CT attenuation to distinguish this lesion from anostosis and call this is osteoblastic metastasis. Also, you should aware of some limitation and other benign osteoblastic lesion that can mimic metastasis. And hope this talk is useful, and I'm happy to take questions at the end of this session. Thank you for your attention.
Thank you, Dr. Nataya. You always deliver excellent lecture. Dear participant, you can type your questions at the chat box below the screen. Just scroll up your screen. Our next speaker is Dr. Rosie Setyawati, Associate Professor and Head of Department of Radiology, and she is a Secretary of Indonesian Radiological Society. Her talk will be titled Imaging of GCT of the Bone and its Mimic. Please, Dr. Rosie, you can start.
Good morning, ladies and gentlemen. First of all, I'd like to thank to the committee of this annual EMS meeting for inviting me in the wonderful event. And for the chairman, thanks for introducing me. At this time, I'm going to present my talk about imaging of GCT of the bone at mimics. I have nothing to disclosure. The giant cell tumor is a benign, locally aggressive tumor with the bone destruction and with malignant potential. The giant cell tumor occurs more in the female, and it usually occurs in the skeletal. Mature patient is about 20 to 40 years old. The giant cell tumor occur more in the distal femur, but they can occur in the proximal tibia, distal radius, proximal humerus, hand, spine, and the sacrum. The pathology fracture may also occur in the 50 to 65% of cases, can invade the soft tissue, and the GCT tumor with malignant stroma are prone to behave malignant fashion and rarely metastasize of involving the multiple bones. In pathology, the giant cell tumor contains large multinucleated giant cell in addition to mononuclear stromal cell. The stromal cell look like the nuclei of the giant cell, and the tumor may have secondary aneurysmal bone cyst and the cystic aneurysmal component. So the blood-filled cystic cavity lined with a thick membranous structure that comprises mononucleated giant cell and mononuclear cell. The plain X-ray is a primary diagnosis modality, and the lesion is usually geographic. And the GCT has 2 until 5% incidence of metastasizing to the lungs, and the risk being greater in the case of recurrent tumor. And at average of 3 to 4 years after initial diagnosis and index treatment. Pulmonary metastasis in GCT, sometimes called benign pulmonary implants, are typically slow growing and usually amenable to surgical resection with a prospect for cure. The radiographic feature of the GCT begin in the metaphysis and extend to subarticular location once the epiphyseal line has closed. And the lesion has a lytic radiolucent lesion, epimetaphyseal location located eccentrically, has a significant bone expansion resulting in subbubble appearance, margin generally well-defined and sometimes ill-defined, no sclerotic margin, rarely extend to the articular cartilage, and however, it can break through the cortex into the surrounding tissue. With other modality, CT scan can show the intraosseous extension, the intraarticular spread, the cortical breadth, and define the site of windows for the biopsy. The MRI can show us the soft tissue spread, the joint spreads, locate the neurovascular bundle, fluid levels, and we can do the diffusion perfusion MR spectroscopy to find the potential malignant lesions. Densitography is less useful because of its inconsistent uptake, and some cases will show the classical feature of donut sign and can detect the multiple foci. And angiography will help us to locate vessels type of feeders for embolizations. And this is the case of 25 years old female, well-defined geographic lesion within the lateral portion, the distal femur. And the case of 40 years old male, grossly expansile and heavily trabeculated solvable geographic lesion involving the entire subarticular surface of the distal radius. This is a case 67 years old female, grossly expansile geographic involving the entire sacrum with peripheral ill-defined margin. This is 24 years old female with the lytic expansile lesion in the calcaneus, and from MRI showed the soft tissue met with the fluid lesion that representing the GCT with secondary ABC. This is the CT scan of 27 years old female that there is a well-defined geographic lesion with the distal portion of femur with no cortical breakthrough and no intraarticular extension. And this is 40 years old female patient that there is an eccentric ill-defined lytic lesion in medial epimetaphysis of the distal femur, and from MRI show the tumor extend to subcondylar bone plate with endosteal cortical involvement. This is a case of this GCT of the distal femur that the radionuclide bone scan rarely provides the additional information because the degree of tracer uptake does not correlate the histologic grade of the tumor. However, an abnormal uptake pattern was found in 49% of cases, resembling a donut sign that there is an intense uptake in the periphery with relative lesser uptake in the central portion of the tumor. And the Anakin et al. Make a clinical radiology classification of the GCT at stage 1 as a latent, refers to a confused totally bone asymptomatic inactive in bone scan and histologic benign lesion. And stage 2 as active refers to an expanded cortex with no breakthrough, symptomatic of the pathologic fractures, active in the bone scan and histologically benign lesion. Stage 3 aggressive as refers to a rapidly growing mass, cortical perforation with a soft tissue mass may metastasize, symptomatic extensive activity on bone scan and histologically still benign. And stage 4 malignant refers to sarcomatous lesion contiguous with the benign lesions. The Kampanaki et al. Also make the 3 grades of GCT based on the radiography appearance as latent of the grade 1, active and the grade 2, and aggressive the grade 3, similar to the Anakin classification. There is a same of secondary phenomenon observed in conventional giant cell tumor that we can see there is in giant cell tumor may have a secondary aneurysmal bone cyst, may having fibrositocytic xanthomatous changes or necrosis, or maybe also having a malignant transformation or dedifferentiations. In lung implants, it may occur in the solitary or multiple manner, and also with the soft tissue recurrence. And Kransdorf and Marpe et al. And Mira et al. Describe the modification of classification for malignant GCT. First is benign metastasizing GCT, correspond to the GCT with the occasional lung nodules. The true malignant GCT is a high-grade sarcoma arising in GCT as a primary or differentiated GCT. And secondary malignant GCT is as at the site of the previously documented GCT after irradiation or other intervention or benign GCT. And the last is giant cell red sarcoma occurring associated with other entities such as severe polyostotic patch disease. This is also the study with malignant in the malignancy in giant cell tumor or bone literature view that it is found that there is incidence of primary malignancy about 1.6% and for the secondary malignancy about 2.4% of cases. And the primary malignancy appear to be associated with a better prognosis than secondary malignancy as well. And the MR imaging features helpful to predicting the clinical behavior because we cannot do this on the radiographic finding and helpful to evaluate the potential malignant lesions. What happened in T1 that we can show the low to intermediate solid component with low peripheral signal in the portion of the tumor. And T2 show intermediate to high signal. The high signal in adjacent bone marrow represent the inflammatory edema. And the fluid level is shown in the 10 to 14% of the patient and to be secondary of AAPC. And this is a case of malignant transformation of the GCT in 55 years old male that we can see there is after curettage and there is a graph in this proximal tibia, and after 23 years old after the grafting, so we can see there is a suspicious or new lesion on the anterior part with a soft tissue involvement here. So we can see more obvious on the CT scan that there is a more destruction bone on the tibia and the previous lesions surrounding the graft. And the MRI, we can show the more extensive soft tissue, and there is a bone marrow replacement regarding to the malignant transformation of the GCT. And there is a study of the diffusion that the giant cell tumor occur more exhibit early arterial enhancement and low ADC value. It could be happen because some intra tumoral hepatocellular component, or maybe this is also due to the hemosiderin product within the tumor can affects the lower ADC values as well. There is another study of the triple phase dynamic MRI that may helpful to predict malignant transformation of giant cell tumor of the bone. That DZE MRI appear to helpful method to find the new clues to predict malignant transformation on GCT, that the malignant GCT will show the step upward slope followed by early and rapid wash out phase. And rather than the TIC of giant cell tumor and recurrent giant cell tumor with show the slower or maybe the lower step slope followed by a relative slow wash out phase. But in this study, the mean slope value among the groups were no significant differences. So this is the case of benign GCT that we can see there is ill-defined expansolytic lesion of the distal femur with the soft tissue involvement, and we can see here from the MRI there is a heterogeneous mass with the solid mass with secondary ABC with the fluid level and the necrotic area. And the ABC showed a higher ADC value, about 0.923 and 1.1. And the TIC type is grade 2 and grade 3 of TIC pattern. This is proven by benign giant cell tumor. This is another case of the malignant giant cell tumor that we can see the more destructive pattern of the lesion as well. So we can see the pathologic fracture with a very obvious or soft tissue involvement with expansile ill-defined lytic lesion here in the proximal femur. And MRI, we can show there is a more obvious soft tissue mass with many signal intensity inside, and ADC values show the lower ADC about 0.139 until 0.747, with the TIC type or pattern type 3 and type 4. This related to the malignant of GCT proven by these pathology finding. GCT has a mimicking lesion that we have to consider. Firstly, about the bone tumor of parathyroidism is a one mimic lesion of GCT of the bone, especially when compared to multicentric GCT, because the histopathologic feature of both bone tumor and GCT is similar. So it is important to give the pathologist all the suitable clinical imaging result data so they could come into the definite diagnosis based not only the bone specimen. So the giant cell in the bone tumor will show more smaller giant cell with the nodular arrangement, and the stromal cell and more spindle if we compare to the GCT finding. So this is a case. There is a misdiagnosed the bone tumor or hyperparathyroidism misdiagnosed with multifocal giant cell tumor. So this is a case how we have to be aware with the when we make a diagnosis of the multicentric giant cell tumor. How about the chondroblastoma? The chondroblastoma is a one of mimic lesion of this prone this is GCT, because of the chondroblastoma have more likely having in the immature skeletal patient rather than the GCT. And usually the epicenter of the chondroblastoma having say in this more in the epiphysis than in the GCT, more likely in the metaphysis. And sometimes in the chondroblastoma will show the more sclerotic burden, and sometimes there is a matrix ring of arch calcification due to the chondroid matrix. And how about the GCT with secondary APC and with APC, that on MR we can see there is a soft tissue mass with the flip level representing the secondary APC, that this soft tissue mass should not be present on the truly or purely APC. So in the APC we can only see the flip level. In another case, a 37 years old female patient, that we can see there is a mass, a soft tissue mass with the fluid level. We can support this as a GCT with the secondary APC. A GCT with sclerotic portal with the fibrous tumor also we consider as the mimicking lesion, because the differences is the epicenter sometime in the fibrous tumors, more likely in the metadiaphysis location rather than in GCT, rather happen in this metaepiphysis. And if we compare with other fibrous tumor, if to the GCT, that in the fibrous tumor from the benign to the aggressive one, we can see the lesion is more trabeculated with a more sclerotic border. Yeah. And we can see this also involve the diaphyseal area or locations as well. So telangiectatic osteosarcoma is also one of the mimic lesion of the GCT, because since the telangiectatic osteosarcoma and giant cell rich type of osteosarcoma doesn't have any osteoid matrix as usually seen in the conventional osteosarcoma. So that's why this put osteosarcoma also being a mimic lesion with the GCT. But the difference is from the X-ray that we can see the more broad zone of transitions if we compare to the GCT as well. But in CT scan MRI, we can see there is a soft tissue mass with the fluid level that is classic for the telangiectatic osteosarcoma. The giant cell osteosarcoma also have a more broad zone of transition as well. In this case, that we can see this is osteolytic ill-defined in the proximal fibula, but we can see on MRI, we can see the extensive soft tissue and bone destruction of proximal fibula, and in diffusion, we can see there is a restricted diffusion and with the lower ADC and show the early enhancement and the plateau type of the IC pattern. And if we found demultiplication and in patient over 40 years of age, we have considered about multiple myeloma, MBD, and bone lymphoma as our consideration as a mimicking lesion of the GCT. So we have to completing all the additional or information of the patient so we can reach to our diagnosis that usually the multiple myeloma, MBD, and bone lymphoma may also appear as osteolytic lesion in the epimetaphyseal feature. So it's very important to consider about it. And the GCT when happen in the sacrum, so usually is start in the ala sacri, differ from the chordoma usually occurred at midline or sacrum. So we come to in the conclusion that GCT of the bone is typically benign but may demonstrate aggressive imaging features. The recurrency rate of the GCT is higher. The challenge in the accurate imaging diagnosis of malignant GCT have been highlighted in my talk. And GCT can mimic or be mimicked by a variety of other bone lesions so that the comprehensive understanding of each bone lesion characteristic is very important in management of GCT. Thank you for all the attention.
Excellent lecture, Dr. Rosie. And our next speaker will be talking about spinal hemangioma. Is it incidental findings or important imaging findings? The speaker is Dr. Sri Andriani Utomo. She is a senior radiologist from Dr. Sutomo General Academic Hospital and Radiology Department, Medical Faculty of Universitas Airlangga, Surabaya. Please, Dr. Sri.
Good morning and good afternoon, everyone. How are you? I hope all of you are well and healthy. Before I would say thank you to the organizing committee who has allowed me to share my lecture with all of you. Spinal bone hemangioma, incidental or important imaging finding. I will overview first about general consideration and then classification, imaging findings, differential diagnosis, complication, and at last take-home point. General consideration, hemangioma or vertebral bone hemangioma usually is benign lesion, most often located in lower thoracic and upper lumbar spine, mostly asymptomatic, more frequent in females, and peak incidence is in 40s, multiple in up to 1/3 of cases, most often occur in the medullary cavity of bone, and microscopically there is hamartomatous proliferation of vascular tissue. And it can be classified as to cavernous, capillary, arteriovenous, and venous type. Spine hemangioma are usually capillary type. Now, how about the imaging point of view? We have a classification for spinal bone hemangioma in typical hemangioma, atypical hemangioma, and aggressive hemangioma. Now, what the difference between typical and atypical, also aggressive hemangioma? For typical hemangioma, for the location, mostly in the thoracic and lumbar spine. And for atypical and aggressive hemangioma, usually in thoracic 3 to 9. And for the gender, both typical, atypical, and aggressive hemangioma, slight female predominance. And how about the number? Usually for typical bone hemangioma, there's often multiple. But for atypical and aggressive, often solitary. And the vertebral body, usually for typical vertebral body hemangioma, just only in part of the vertebral body. But for atypical and aggressive, mostly entire vertebral body, involves neuroarts and extraosseous. And for the MR signal characteristic, typical bone hemangioma usually with high in T1 and T2 because of the fat adjacent the hemangioma. And for atypical and aggressive hemangioma, this heterogeneous mix in T1 and T2. And the cortex and typical are normal. For the atypical and aggressive bone hemangioma, usually is expanded and poorly defined. Honeycomb appearance for this typical is regular, but for atypical and aggressive bone hemangioma, it is irregular. And for soft tissue extension, usually in typical, the soft tissue is normal. But for atypical and aggressive, usually extend to the extraosseous. And for paraspinal vessels, usually in typical, normal, but for atypical and aggressive bone hemangioma, it is enlarged. Now, what we can see in imaging. So, imaging findings in plain X-ray. Radiography is usually the first means of imaging hemangioma, and prominent trabecular pattern from resorption of trabeculae, usually the horizontal trabeculation is resorbed, and then there is a large vascular channel produces vertical striation. Overall density of vertebral body is increased. The cortex is not thickened, and vertebral body is not increased in size. And small hemangioma will not be visible on conventional radiographs. And how about in CT scan? There is thickened vertebral trabeculae that produce a corduroy and polka dot appearance. So when we see in sagittal, it shows a corduroy sign. But in axial slice, we can see there's a polka dot sign. Bone destruction and soft tissue extension may be present but are rare. And in MR imaging, MRI shows extraosseous components better and depicts the hemangioma components as fat and water. Thickened trabeculae appear as low signal area in both T1 and T2 images. T1 is just high intensity signal due to its fat component, and T2 bright or high intensity signal usually greater than on T1 due to its high water content. Depending on the balance of fat and vascular components, they may or may not be hyperintense on still images. And T1 post-contrast it will show significant enhancements seen due to high vascularity. Now you can see in typical vertebral hemangioma, this is T1 and T2, and what we see here in CT scan sagittal slice. So what we see here in T1 and T2, there are prominent of vertical bony trabeculation with adjacent fat intensity that we can see in T1 and T2 shows hyperintense signal. And other part, this is not bone hemangioma, but this is fatty changes of the vertebral body. In CT scan, we can see the prominent bony trabeculation with corduroy sign. And in axial slice, we can see polka dot sign that show hypointense in T1 and T2 in MR. And in CT scan, we can see the polka dot sign with a hyperdensity. Okay, now we see how about this in T1, T2, and stir imaging. We can see in T1 and T2, there is prominence of the vertical bone intraarticulation here with adjacent fatty changes that we can see in T1 and T2. It shows hyperintense signal, and in stir imaging, there is saturation of the fat and shows hypointensity. And this, in axial, we can see there is a polka dot sign with adjacent fatty changes. Now, how about the atypical bone hemangioma? For the atypical bone hemangioma, there is an irregular of the trabeculation that we can see and hypointense signal in T1 and T2, and also when we see the adjacent fatty changes is not very clear. In T1 and in T2, it shows slight hyperintense, and the outline is not very well defined. And what we see in axial, we can see there is also polka dot sign with adjacent fatty changes, but the fat tissue is not prominent like an atypical, like in typical bone hemangioma. And T2, it shows hyperintensity because mixed with water intensity. Now we see the aggressive spinal hemangioma. So we have case 50 years male with aggressive epidural and bone hemangioma. So what we see here, we see there is looks like destruction, hypointensity in T1, and in T2 it shows slight hyperintense, but we see there is a bulging mass in the posterior epidural space, slight indentation to the thoracic cord. And what we see here, in parasagittal section, we see this lesion in the posterior vertebral body to the facet joint. You can see, and this in T2 slight hyperintense signal. But what we see here in T2 fat set study, we can see there is a hyperintense extension of soft tissue mass from the bone, from the posterior in the spinous process that extend to the posterior epidural space. You can see here in the posterior vertebral body to the facet joint. And with contrast study, it shows vascular contrast enhancement that we can see like a tubular and also serpentine sign. It doesn't look like malignancy for this lesion. And what we see in axial is in the posterior of the vertebral body, pedicles also involved here, and lamina, and also adjacent or extension to the posterior epidural space here. And what we see in another place, we can also find in both sacroiliac joint, in both this os ilium and also in the sacral area, there is also vascular contrast enhancement. So this one, we can see there is a vascular contrast enhancement with tubular and serpentine type. So what we see here, this one in the os ilium area and this sacral area. Also, so this is an aggressive bone hemangioma for this patient. So now we see how about the differential diagnosis. Bone marrow fatty changes, fatty and plate degeneration. This is part of the differential diagnosis for this aggressive or atypical bone hemangioma. And herniatitis, synovial granulomatous infections, neurogenic tumors, lymphoma, meningioma, and also metastasis. And pure epidural hematoma. So now we see here, this is a fatty end plate degeneration with a Modic type 2. It shows fatty changes, but this is not hemangioma. And there are multiple flocculated fatty changes, and this is not hemangioma, but this is a fatty changes due to early osteoporosis. And what we see here in axial, we don't see also the polka dot sign, just only fatty changes of the vertebral body. And APC, aneurysmal bone cyst, we can see there is a septated with hyperintense signal and T2 fat set, and also we can see in the cystic lesion here, we see the fluid level with many kinds of different ages of the blood content. So this is an aneurysmal bone cyst. Now, Langerhans cell histiocytosis, also part of the differential diagnosis with planar of the vertebral body, and there is also epidural space mass here. And this is intradural extramedullary lipoma. So we can see in T1, T2, and this in T2 fat set, it shows a hypointense signal. This is an intradural lipoma. And this is an epidural cyst. So we should make a differential diagnosis if this is not bone hemangioma that extends to the epidural area. Metastasis, also we can see bone destruction here in the spinous process with bulging mass that extend to the posterior epidural space. And this one also metastatic process. And this is not prominent bony trabeculation, but this is a destruction of the vertebral body with bulging soft tissue mass. And this one, this is infection, spondylodiscitis with epidural abscess here. And also this one, what we see here, this is an epidural cavernous hemangioma with heterogeneous vascular content that shows contrast enhancement. So this is not infection, and this is not soft tissue mass in the epidural space. And this one also in the epidural space, in the posterior epidural space, but this is an epidural hemorrhage. And what this one, we can see, this in T1 shows a hypointense signal and hyperintense signal in T2 in the yellow ligament. And what we see here, so this is synovial cyst. But this is different. This is not synovial cyst. We can see there is soft tissue hemangioma. And then this one, this is a blood content. So this is an epidural hemangioma with hemorrhage that we can see there is a fluid level in this cystic lesion. So this is not synovial cyst. Okay, and now what we see, this 40-year-old male with back pain that extends to the left leg. So what we see here, this is not blood content, but this is perineural cyst. Okay, so this is a perineural cyst, and we don't see epidural hemangioma like the previous picture. Now, how about the treatment of the vertebral bone hemangioma? Observation: treatment is instituted only if they are symptomatic and may include vascular embolization prior to surgery, surgical excision, vertebroplasty, and ethanol injection. And the complication is pathologic fracture, hemorrhage when it occurs. It usually iatrogenic, and thrombosis, displacement of adjacent nerves producing pain. Okay, so we know Now we go to the last of my lecture, a take-home point. Spinal hemangioma are most often benign in CT imaging finding with a good prognosis. However, a rare subset of them can be aggressive with devastating neurologic sequelae. Radiologists should be aware the various imaging features of the aggressive spinal hemangioma that can simulate many pathologies like a primary bone malignancy or metastasis. As aggressive hemangioma often mimic other aggressive spinal lesions, so additional imaging modalities such as CT, angiography, and radiography are usually needed to make a definitive diagnosis. Thank you.
Thank you for a very informative lecture, Dr. Sri Andriane Utomo. Our fourth speaker today is Dr. Natasan Tidam Baranathan. He is not only a senior consultant in radiology, but he is also the head of the Department of Radiology, Apollo Hospital, Greens Lane, Chennai, India. His topic will be multiphases of osteosarcoma. Please proceed, Dr. Natasan.
Good morning to all of you. It is indeed a great pleasure in participating the 24th annual scientific meeting of Asian Musculoskeletal Society. I thank for giving my opportunity to be and to present this particular topic, multiphases of osteosarcoma. All of you know the osteosarcoma is the most common tumor of the young, with the accounts for nearly about 15% of the brain bone tumors. Okay, this osteosarcoma having varied presentation depends on the histology and depends on the location and depends on the treatment changes. So we radiologists has to be familiar with this radiological feature and to guide the clinical colleagues for the appropriate treatment. So the imaging features are often depends on the location, whether it is arising from the common site like a long bone or uncommon site like flat bone. The histological type also subtype will be quite often change the radiological feature. Again, the common condition like osteoblastic variety and as well as other osteolytic type of osteosarcomas occurs in some of the conditions like subtype of osteosarcoma can have the different feature and the during evolving phase of the osteosarcoma, whether this we see the early phase or very advanced stage, the radiological feature quite vary. The radiological feature may be vary depends on the associated complication of the disease process, like sometimes may be associated with fracture or maybe other presentations. The radiological feature of osteosarcoma depends on whether this is primary or secondary type, or can be de novo or maybe post-treatment process. So we radiologists has to be familiar with these changes, and we should be guide the clinician. The primary osteosarcomas are commonly conventional intramedullary osteosarcomas. Intramedullary osteosarcoma have a subtype. Okay, having high grade intramedullary osteosarcomas, conventional osteosarcoma, telangiectatic osteosarcoma, small cell osteosarcoma. This accounts for majority of the intramedullary high grade osteosarcomas. Osteoblastic variety are 77 and chondroblastic are 13% and fibroblastic around 10%. The other subtypes are low grade central osteosarcoma. Low grade central osteosarcoma also have the sclerotic origin, but you often have them mistaken as a fibrous dysplasia. The other subtype may be osteosarcomatoid entity. It can have multiple osteosarcomas. Then nanotic type of tumor occurs in the mandible. Also, it is distinct entity of osteosarcomas. These osteosarcomas, intramedullary high-grade osteosarcomas, often common prognosis and the almost same prognosis and with the treatment. The next entity are surface osteosarcoma. The surface osteosarcoma, it can be purely intracortical or paraosteal or periosteal or high-grade surface osteosarcomas. All of you know the central conventional osteosarcoma, otherwise so-called high-grade intramedullary osteosarcoma, accounts for 75%, commonly occurs in the teenage group, painful mass in the metaphysis, the particularly lower end of the femur or upper end of the tibia, with the dense bone of some mass with the speculated margin, ill-defined zone of transition, and as well as the metaphyseal location. Depends on the type, it quite variable nature, more sclerotic type of osteoid matrix, as we see the classical type. The more typical form of osteosarcomas, which can occur more sclerotic, more dense bone, with the bone forming tumor, with the osteolysis, with the cortical desiccation, or maybe a Codman's triangle within the metaphyseal location, a commonly teenager. It can be more osteoid bone formation within the bone, with the soft tissue also have that more sclerotic margin, or maybe a dense bone with the cortical destruction, sun ray speculations. So these type of tumor very classical of conventional osteosarcoma. There's aggressive periosteal reaction in the form of a Codman's triangle, laminated appearance, hair and on appearance, sunburst appearance can occur with associated soft tissues. The very classical osteosarcomas having this type of feature. All of you familiar with. The typical feature of osteosarcoma in a atypical location, quite slightly variable. It can occur like atypical location, like a flat bone, can have that hair on end appearance or sunburst appearance. There will be slightly different way of type of periosteal reaction with the large soft tissue mass. It can slightly different from the conventional other osteosarcomas. Telangiectative variety of osteosarcoma, it is a more high grade. It is like a more of permeative nature with a high grade with a lot of hemorrhagic component, often mistaken as ABC pattern or parallel striation patterns can occur. This can occur various fluid level, can association with sometimes maybe a retinoblastomas, particularly in P53 tumor suppression gene. It is accounts about 4 to 11% of the cases. So telangiectative osteosarcoma totally will be more of purely lytic with the fluid level. Small cell osteosarcoma. Small cell osteosarcoma is around 1 to 4%, typically predominantly permeative nature, more lytic and medullary expanding lesion as in this case, without much of sclerosis, with may cortical breakthrough or may not be with the periosteal reaction, often mistaken as Ewing's. Because of them, even histological also, it look like a small cell with the lack of cellular uniformity, with associated osteoid and fine reticular pattern. Typical without much of sclerosis can easily mistaken as a Ewing sarcomas of this type of small cell osteosarcoma. The next entity, a low-grade central osteosarcoma. The low-grade central osteosarcomas, unlike conventional osteosarcoma, it is very low-grade. It is more sclerotic varieties and more dense bone with a slow-growing tumor. Okay, this will be often mistaken as a something sometimes fibrous display because of the ground glass appearance, or can be non-active fibroma, as in this case. Maybe MR will be ideal situation to assess the extent of the disease process. Here is an example of the X-ray. It's not seen, very well seen in the earlier. After 1 month, become very obvious lesion. It's a low-grade central type osteosarcoma mimicking a fibrous dysplasia kind of thing. Chondroblastic osteosarcoma is another variety, more of occurs in a younger age group, often mistaken as a chondrosarcomas. But the chondrosarcoma and chondroblastic sarcoma can be differentiated by the age-wise. Chondroblastic sarcoma is 16 age group, whereas chondrosarcomas are more than 40-50 years. But the important feature, though the CT maybe show the calcification better, but the MR will be calcific lesions are seen T2 bright intensities as we see in this case, the large soft tissue mass. Consider this entity of chondroblastic osteosarcomas. Another chondroblastic osteosarcoma occur, the mandibular osteosarcoma, around account for 6.5%. It is occurs in the exclusive for mandible, alveolar ridge or maxillary random body of the mandible. Histologically, it is a very distinct entity of the other osteosarcomas. This chondroblastic variety. On imaging, sun-ray speculation, lighting area with a large mass lesion, the typical of osteosarcoma features will be there in the naphthetic type of osteosarcomas. Then coming to the surface osteosarcoma can be intracortical. It is confined to only cortical lesion with clear-cut margin, with the lysis, with there is a mineralized osteoid matrix with sclerotic areas on CT examination. This is a typical surface intracortical osteosarcoma. Another way it is called, all of you know, the paraosteosarcoma is a very low grade variant, occur slightly old age group, which looks like a myocytic ossification. On imaging, this is a 48 years old person having that typically along the periosteal lining that there is a lesion with a narrow stalk appearance, with that typically radiolucent areas are seen between the periosteum and the mass with a narrow stalk appearance, often mistaken as myocytic ossification. Myocytic ossification usually have dense periphery, whereas periosteal osteosarcoma will very lucent periphery. With this finding, we can easily make a paraosteal osteosarcoma. Next, almost similar variety, it is a more aggressive form. There is a periosteal osteosarcoma, a very similar appearance. It locates subperiosteal location. Where the classical feature will be maybe a deep layer, a periosteum involvement, and with the cause cortical scalloping, or maybe saucerization occurs with the large soft tissue mass with the dense bone. This very almost close to the periosteum. You can think of periosteal variety. The periosteal varieties are more aggressive, and paraosteal osteosarcoma is very low grade type. Another periosteal type, similar periosteal osteosarcoma, can occur in the diaphysis location, but only the cortex shows circumferential involvement. This is often involved the entire circumferential bone of the cortex involvement. This classical appearance of high-grade surface osteosarcoma. This is a pleomorphic cytology with the chondrite mixed background. Osteosarcoma during evolving phase of different stages can have varying appearance. As in this case, early phase sometimes very difficult, very subtle appearance, maybe lytic lesions or maybe small dense bone, often mistaken as a benign lesion, or maybe can present with the pathological fracture with the lytic areas, easily mistaken as osteomyelitis or maybe Ewing sarcomas. Sometimes the early phase of osteosarcoma totally non-specific, as in this case lytic, and there is a subtle sclerotic lesion with the cortical erosion in a younger age group, easily mistaken as a osteomyelitis, and or sometimes you can get mistaken as Ewing's, as is this case also. With this CT, MR will be very ideal to assess the extent of the disease, but particularly marrow involvement of the physis and epiphyseal plate involvement. It is a very good value for particularly limb salvage surgery, how much extent of the disease process occurs in the marrow. So the late phase of osteosarcoma also sometimes non-specific, because purely lytic lesion with the peripheral rim of sclerotic region, often mistaken as some kind of benign process, as in this case, or maybe you can get sometimes subtle periosteal lesion in the late stage. A non-ossified matrix can get non-specific features. This is another case of 12 years old pain in the shaft of the leg, and there's a small onion peel appearance, like appearance with there is edema and a low skin intensity area. We consider possibilities of stress fracture because of pain, younger age group, and after 2-3 years shows patient came with the similar complaint. The lesion becomes grown as a mass forming lesion. Confirm actually this is not a stress fracture. This turned out to be osteosarcoma biopsies. Secondary osteosarcomas, not uncommon. Secondary osteosarcoma can occur in a Paget disease, or could be bone infarction, a benign lesion. This is a patient having SLE. There is a large bone infarct. Then later part, this we do MR, this shows that there is a lesion with the more soft tissue component. It is a secondary osteosarcoma occurs in a bone infarction. Osteosarcoma can occur in secondary in the Paget disease, as in this case, large Paget disease has seen the very sclerotic margin with the thickened calvarium, the inner table, outer table with the large soft tissue mass. Consider the possibilities of soft tissue mass. Paget disease, osteosarcoma occurs in 1 to 2% of the case. Multifocal osteosarcomas can have the almost like a metastatic skip lesion. The both multifocal sarcomas and metastasis have similar prognostication because the T1 mirror image ideal sequences to see as the extent of the disease process, as in this case. Multifocal osteosarcoma metastasis, the best imaging modality, nuclear bone scan or a PET scan. You can show the extent of the disease process. And when we are suspicious osteoblastic metastasis, osteosarcomatosis, think of always nuclear bone scan, a PET scan. Sometimes can other different diagnoses like a fibrous dysplasia, CRMO, chronic recurrent osteomyelitis, Paget disease, Adam disease, also the differential diagnosis. Osteosarcoma during course of the treatment and post-treatment changes quite varying presentation and also the very radiological features, as in this case. This is a patient having chondroblastic osteosarcoma with a neoadjuvant therapy. Patient having that large lesion in the iliac bone with the dense lytic areas, say the dense, there is a low dense area, peripheral enhancing lesion. Often it can be look like a recurrence or maybe a post-treatment changes. This case, neoadjuvant therapy, a lot of necrosis with the peripheral enhancing areas. Often this type of challenging time of whether treatment or maybe recurrence of the lesion, we have to do other modality like PET image, or you can say other technique like dynamic contrast MR imaging. Dynamic contrast imaging, it shows the type of pattern of the curve. The type of pattern of curve is very plateau and consistent with this tumor. If there is the curve comes with the normal range with the it is a good response with the chemotherapy. This is a post-treatment changes. So this pattern of curve easily can make a diagnosis. Atypical osteosarcoma sometimes mimic other tumors, as in some of the cases I will show. Here the 6 years old boy with there is a girl has a large lytic lesion with there is expanded lesion. Initially thought this will be like aneurysmal bone cyst. After 6 months, show this very aggressive lesion, and this has become. We did MRI show there is hemorrhagic component, expanding lesion, the lytic lesion. Think of the this is like ABC. We thought maybe it turned out to be a tail-injected osteosarcomas. So tail-injected osteosarcoma, fluid full level hemorrhagic areas, often this particular mistaken as a ABC. Giant cell rich osteosarcoma. This is a large expanding lesion in the subchondral location, peripheral rim of sclerotic areas. Okay, usually mistaken as a giant cell tumor. This case turned out to be a giant cell rich osteosarcoma, as is in the literature. Similar case where this case also osteosarcoma, giant cell rich osteosarcoma, mistaken GCT and treated with bone prosthesis. So often this type of atypical manifestation sometimes very challenging. Another case, large look like GCT, typical location expanding without much of sclerosis, and this is turned out to be a tail-injected osteosarcomas. This is a 10 years old boy, large expansive lesion in the metatarsal bone with the expanding, with the sobable appearance, with the thinned out cortex, with a lot of edema in the MR images with low intensity areas, with the bright expanding lesion. Often we thought of a benign lesion like a chondromas or chondroblastomas, but this is a case where chondroblastoma mimic a chondroblastoma like osteosarcomas. Yet another case, this is a typical exophatic lesion like osteochondroma. Parastral osteosarcoma also have a similar appearance. So, but the MR shows the large soft tissue element and there is a bone forming lesion, and this is with increased vascularity. This case turned out to be a dedifferentiated parastral osteosarcoma. Parastral is usually low grade. When it's become no large soft tissue expanding and rapid growth, think of dedifferentiated paracellulosarcomas. This is a 15 years old girl, yeah, low back pain. Diagnosed CT and MR was done. CT showed that lytic areas with large soft tissue component with the low signal intensity areas. We thought could be osteoblastoma or osteomyelitis changes, but after 3 months, so there is a soft tissue component is more enhancing, more enlarged, and this is a biopsy turned out to be a sacral osteosarcoma. Initially, we thought it was osteomyelitis or osteoblastomas. Okay, so some of the benign lesion can mimic some osteosarcoma, sometimes mimic benign lesions. Here is another patient having large subcutaneous lesion with a lot of speculated calcification with abutting the muscular plane, and there is an extensive sun-ray speculated margin. Biopsy turned out to be a extra osseous osteosarcoma. We thought it could be a myocytic ossification, and it turned out to be an extra osseous osteosarcoma biopsy. Yet another case, 65 years female, look like a large sclerotic lytic lesion and involving the entire bone and slight subtle expanding of the bone. On CT and the MR, there is large soft tissue parametrial areas, and the CT axial section, so there is slight expansion that give a clue. Case of this is a Paget disease with osteosarcoma mimicking a spinal metastasis. So, ladies and gentlemen, imaging feature of osteosarcoma quite vary, complex and wide spectrum. It depends on the histological type or location or the stage of the disease where we see, or the response to the underlying tissue component. So, radiology has to recognize this imaging feature is very important, vital role to the clinical colleagues for the treatment modality to the patient with the osteosarcoma, and thereby result improve the clinical outcome. Thank you very much for your attention. Okay, is there any queries? Please write to this email address. Thank you very much.
Thank you, Dr. Natasan, for very informative lectures. And now, ladies and gentlemen, we wrap up session 6. We will go directly to join the best AMS paper presentation by Professor Nisar Al-Naqshbandi from King Saud Hospital, Saudi Arabia, with the title Therapeutic Effect of Geniculate Nerve Radiofrequency for Chronic Knee Pain. Please, Professor.
Hello, my name is Nizar Al-Naqshbandi, and I'd like to thank this organizing committee for giving me the opportunity to share my work about the therapeutic effect of geniculate nerve radiofrequency for chronic knee pain. Overview of this lecture, we'll be talking about disclosures, objectives, material methods, conclusion, and examples of the procedure and its outcomes. I have nothing to disclose. The objectives of this talk is to determine the therapeutic effect of geniculate nerve radiofrequency for chronic knee pain by image-guided procedure done on an outpatient basis by the interventional musculoskeletal radiologist. The study has been approved by the hospital's ethics committee. A total of 21 patients ranging in age from 50 to 70 years of age, suffering from moderate to severe osteoarthritis of the knee, graded by the Kellgren-Lawrence classification, grades 3 to 4. All patients failed conservative measures with non-steroidal anti-inflammatory drugs or with physiotherapy. All 21 patients consented to undergo image-guided radiofrequency ablation of the geniculate nerves. A visual analog score was measured at baseline, 1 week, 4 weeks, and 12 weeks post-procedure. These are the results. This is a busy table showing you the age, the number of the patients from 1 to 21, ages from 50 to 70, and that the baseline, most patients had a grade of 8, 9, or 10 out of 10 on the visual analog scale. And at 12 weeks, most patients have dropped to 1 to 2 and almost to 4 out of 10 on the visual analog scale. There was a significant reduction of pain between the baseline and at 12 weeks, with a p-value measuring less than 0.05, significant reduction. This is to summarize the busy table. This is a scattered plot graph showing the response of pain in the visual analog scale between the baseline and 12 weeks post-procedure. As you can see, the patients who had a scale of 10 out of 10 on the visual analog scale have dropped to almost 2 or even 4 or even 1 out of 10. So the conclusion is that radiofrequency ablation of the geniculate nerves of the knee has a significant pain reduction and functional improvement in the elderly patients with chronic osteoarthritis of the knee. It is therefore effective treatment of such cases, and it should be implemented by all interventional musculoskeletal radiologists and has significant role instead of just corticosteroid injections. I'll be giving two examples of the procedure. This is a schematic presentation of the radiofrequency ablation probes placed at the medial superior and medial superior lateral and inferior medial geniculate nerves. This is the exact representation on the lateral view of the needle placements. Procedure is done with image guidance, either with a C-arm image intensifier. The patient are usually awake under conscious sedation and local anesthetic. Usually an IV line is placed in the patient, and broad spectrum antibiotic is given. Cefazolin 2 grams I give intravenously at the start of the procedure. The needle is placed percutaneously towards the shaft of the condyle, epicondyle at the femur, superiorly, medially, superiorly, laterally, and inferiorly, medially. We avoid the inferior geniculate nerve laterally, as it can affect the perineal nerve with disastrous outcome if the perineal nerves get ablated. After that, the probes are connected to the radiofrequency ablation. We use the Avenus cool leaf machine. We test for the sensory stimulation at 50 Hertz, 1.2 volts, and 1.6 volts. Patient usually express heat at 1.6 volts, then you know you're at the geniculate nerve. And then we do the motor stimulation at 2 Hertz at 0.5 volts interval. If there is any shivering of the muscles or reticulation or speculation, then we move the needle slightly laterally as to not affect the motor nerve component of the geniculate nerve. We are only aiming for the sensory nerve. The electrode tip temperature is then raised to 60 degrees for 180 seconds. And one radiofrequency lesion is made for each geniculate nerve. This is an example of 69-year-old male, KL grade 4, severe osteoarthritis. Pre-procedure score was 9 out of 10. Placement of the needles medially and laterally superiorly and inferiorly medially only is, you can see from the C-arm image intensifier. Another excellent procedure is to help these patients who had total knee replacement. As you know, 20% of the patients who had previous total knee replacement will continue to have pain, and if there is ongoing pain despite conservative treatment and infection and hardware loosening and fracture is ruled out, then you can give them the option of radiofrequency ablation of the geniculate nerve, as in this example of this patient who was 70-year-old, had a previous total knee replacement 2 years ago, and all other causes have been ruled out of infection, hardware loosening, or fracture were ruled out. He had the radiofrequency ablation, and the pre-pain score at baseline was 8 out of 10, and at 12 weeks was a 1 out of 10. So this is my short talk about radiofrequency ablation. I think this is a procedure that should be implemented by most musculoskeletal interventional radiologists. procedure is also being done by our colleagues in anesthesia, pain management, and collaboration between these services should be implemented. Thank you very much for your attention. I appreciate your time. Goodbye.
Thank you and congratulations for Professor Nisar Al-Naqshbandi receiving the Best AMS Paper Award. Now, the last program before we have a break, we will proceed to one presentation by our supporting partner, PT Mulya Husada Jaya, represented by Mr. Rizky Heru Setiawan.
Selamat siang, terima kasih atas kesempatan yang diberikan kepada kami. Perkenalkan, nama saya Rizky Heru Setiawan, saya General Manager untuk PT Mulya Husada Jaya, dan pada kesempatan kali ini saya ingin memperkenalkan PT Mulya Husada Jaya kepada teman-teman radiolog di kesempatan kali ini. PT Mulya Husada Jaya berdiri tahun 1995, dan hingga hari ini kita sudah ada memiliki karyawan 350 orang yang tersebar di seluruh Indonesia. Berikut adalah visi dan misi kami PT Mulya Husada Jaya. Visi kami adalah menjadi medical supplier terbaik di Indonesia dengan reputasi yang baik dan mendunia. Hingga kantor pusat kami berada di Lombo Batang, nomor 3, Surabaya, di Jawa Timur. Bagi teman-teman radiolog yang ingin mencatat call center kami, bisa mencatat call center kami di bawah ini. Dan jika ada keluhan atau kendala atau butuh refresh training dan lain-lain, bisa menghubungi call center tersebut. Hingga hari ini kami memiliki 14 kantor cabang yang tersebar di seluruh Indonesia, mulai dari Medan, ada di Pekanbaru, ada di Jakarta, di Bandung, hingga sampai ke Papua. Berikut adalah bisnis partner kami. Jadi kita mengageni beberapa produk, mulai dari GE Healthcare, mulai alat-alat CT scan, MRI, ultrasound, cath lab angiografi, serta juga nuclear imaging. Dan juga tidak lupa kita juga mengageni PACS. Kita PT Mulya Husada Jaya sudah 27 tahun menjadi channel partner dari GE Healthcare, waktu yang tidak pendek, waktu yang sudah cukup lama. Jadi kita sudah hand in hand dengan GE Healthcare, memberikan pelayanan terbaik bagi teman-teman radiolog di seluruh Indonesia. Selain itu kita juga mengageni untuk alat-alat proteksi radiasi dari Kiran. Kita mulai dari apron, tiroid, gonad, hingga kacamata dan headset shield. Selain itu juga kita memegang satu brand juga untuk diargem, jadi dari Korea. Diargem ini kita mengageni untuk alat-alat yang fokus pada X-ray. Jadi ada X-ray analog, X-ray digital, X-ray mobile, dan flat panel detector. Setelah ini saya ingin mengenalkan kepada teman-teman radiolog sekalian, ada 3 produk kami yang ingin kita kenalkan, mulai dari ultrasound, CT scan, dan MRI. Mungkin waktu dan kesempatan saya memulai dulu dari ultrasound. Jadi video produk yang akan kita tayangkan adalah video dari ultrasound yang fokusnya pada dedicated radiologi, itu dengan tipe Logic E10. Oke, mari kita bisa lihat sama-sama video produk berikut. Terima kasih. Oke, demikian video dari video produk perkenalan untuk Logic E10. Mungkin untuk sebagai informasi teman-teman, Logic E10 ini merupakan platform ultrasound dedicated radiologi yang tertinggi yang bisa yang dipunyai oleh GE Healthcare yang dipasarkan di Indonesia. Dan Logic E10 ini sudah tayang dan tersedia di e-katalog bagi teman-teman radiologi, bagi teman-teman radiolog yang membutuhkan informasi lebih lanjut dapat menghubungi teman-teman kami yang ada di cabang. Berikutnya kita akan masuk pada salah satu produk unggulan kami juga, CT scan tipe Revolution Maxima. Tipe Revolution Maxima ini merupakan tipe terbaru yang dikeluarkan oleh GE Healthcare dengan CT scan 64 hingga 64128 dan bisa di-upgrade ke up to 500 flash speed. Oke, tanpa berlama-lama lagi kita lihat video berikut. Oke, kita telah saksikan sama-sama untuk video CT scan dari tipe Revolution Maxima. Salah satu keunggulan dari tipe ini adalah tipe ini sudah mengadopsi teknologi AI atau Artificial Intelligence dan ada salah satu fitur yang unik dari GE yaitu auto positioning. Kalau kita tadi sempat lihat ada semacam satu kamera. Kamera ini adalah membantu teman-teman dari radiografer maupun teman-teman dari radiolog untuk bisa automatic positioning pasien pada saat pemeriksaan CT scan. Jadi fitur ini akan membantu isosentris pasien supaya membantu workflow dari teman-teman untuk mempercepat proses pemeriksaan. Berikutnya, saya ingin mengajak teman-teman radiolog untuk mungkin beberapa teman-teman sudah tahu ada salah satu fitur baru dari GE Healthcare yaitu air coil yang selama ini mungkin teman-teman dari radiolog tahu bahwa coil ini salah satu bagian terpenting dari MRI dan GE Healthcare mengembangkan teknologi air coil untuk membantu dan meningkatkan kenyamanan pasien pada saat pemeriksaan MRI. Mungkin tanpa berlama-lama, kita bisa lihat video berikut. Oke, terima kasih atas kesempatan yang diberikan kepada kami, PT Mulia Usaha Jaya. Saya mewakili PT Mulia Usaha Jaya mengucapkan terima kasih banyak pada Perami dan sukses atas terselenggaranya 10th Annual Meeting of IMRS dan 24th Asian Musculoskeletal Society. Terima kasih dan sukses selalu dan sehat selalu. Terima kasih.
Thank you for PT Mulia Husada Jaya for the informative presentation. To the participants, I would like to announce that AMS and the organizing committee they will have the recording of this presentation available for all of you for 30 days. And now we will have a lunch break until 1:30 p.m. Please come back to the next parallel session and see you later.
pressure course. This session about musculoskeletal infection. I'm Sri Andriani Utomo, the chairperson for this session. We have 4 speakers in this session. The first speaker is Professor Mahesh Prakash. Currently, he is the professor of Postgraduate Institute of Medical Education and Research, India. His talk is about MR imaging of diabetic foot. The time is yours now, please.
Hello everyone, welcome to this AMS scientific session. First of all, I thank the organizing committee of the AMS to providing me this opportunity. My topic is the MR imaging of diabetic foot. As we know that diabetes is a very chronic disease and affect the various organs of the body. The foot complications are the major source of morbidity and disability in these patients. The complications remain a challenge because of the confusing clinical pictures associated with the complication in diabetic foot. There can be various pathology in the diabetic foot, which can be soft tissue involvement or the bony involvement. The common pathologies are soft tissue, cellulitis, tenosynovitis, which can be tendinopathy, neuropathy. But the common and important the pathology are the neuroarthropathy, or we call it Charcot foot, and the osteomyelitis. It is important to diagnose these pathologies as early as possible, because to start the timely therapy and to prevent amputation in these patients. Radiological imaging plays very, very important role to detect these changes and make the diagnosis, as well as in the follow-up cases of these patients. We need to know the correct uses of this modality what we are having, like ultrasound, CT, MRI. We all know that the MR remains the best modality if you want to assess the diabetic foot in holistic way. We have a radiological modality like radiograph, ultrasound, CT scan, and MRI, but today we'll only discuss the role of MRI in diabetic foot. We know that the MRI provides excellent soft tissue contrast resolution and anatomic details. That's why it's a modality of choice to differentiating various pathology in the diabetic foot. The MRI can able to differentiate the osteomyelitis with the Charcot joint, which are the two pathologies are quite important to differentiate because the management differs in these two pathologies. It also helps to identify the pathology which requires surgical or pathology which require the conservative management. And also, we need to map the infections for the surgical resections. The MR protocol can be differs in different institutions. However, in our institution, we do these sequences. So we need to do the T2 weighted images, one at least T1 weighted images, and two at least we have to do in 2 planes. The use of gadolinium may be debatable in various institutions and hospitals. However, if you suspecting the osteomyelitis, the contrast may be needed. In our institute, we always try to give the osteomyelitis until there is a contraindication. Advanced imaging like diffusion weighted imaging and dynamic contrast enhanced imaging can be done depend upon these situations. So this is the list of soft tissue complications and bone joint complications. These are common soft tissue complications like cellulitis, abscess, gangrene, and the bone and joint complications like osteomyelitis and neuroarthropathy. We'll discuss these one by one. Coming to the soft tissue complications, the callus are formed because of change in the biomechanics and also because of the ill-fitted footwear in these patients. They have a typical location, particularly like the head of the metatarsal or the great toe, or maybe in the lateral malleolus. The typical the signal intensity of these callus, they show T1 hypo as well as T2 hypo intensity. They may enhance, but this edema, surrounding edema is very, very little. See this case, this is the diabetic foot patient here. This is T2 fat cell, T1, and this is post-contrast. You can say there is a typical location of the callus formation, which show the T1 hypointense and T2 isointense with minimal enhancement. Ulcer are because of the breakdown of these callus. The neuropathy is the contributing factor for these ulcer formation. MRI shows the disruption of the skin and skin with the raised margin. The signal of these ulcers depend upon the stage of the ulcer. They may show the peripheral enhancement. See, this is case of foot ulcer. You can say there is a arrow shows the typical the foot ulcer with the raised margin. They shows enhancement, and you can see there is a tract, the sinus tracts also. Cellulitis means there is inflammation of skin and subcutaneous tissue. The MRI shows the loss of fat signal in T1, hyperintensity on T2, and they show diffuse enhancement. See this case of cellulitis in diabetic foot. Here you can say there is inflammation of the subcutaneous tissue. This is T2 weighted, T1 fat set, and this shows minimal enhancement in this location. This is a typical case of cellulitis. Myositis, in this case of myositis, we can see there is a inflammation and edema in the muscles, and they can show minimal enhancement also. Abscess are resulting due to the chronic infection, which lead to the abscess formation. They may be seen adjacent to the ulcer. On MRI, they are usually well-defined hyperintense lesion, and on contrast, they show peripheral enhancement. If you don't do the gadolinium enhancement, they can be missed as a cellulitis or myositis. See this case, this is T2 fat set, and this is post-contrast imaging. Here you can see there is hyperintensity in the muscle, and you can say there is a peripheral enhancement and central necrotic area, typical the imaging feature of abscess. Gangrene refers the soft tissue necrosis. It can be dry or the wet, depend upon the presence or absence of infection. MRI shows the unenhanced, devitalized soft tissue with defined border. There can be liquefaction in these gangrene cases. Here you can say this is a case of gangrene. You get T2 fat set and post-contrast enhancement with the typical imaging features of T hyperintensity, T2 hyperintensity, and non-enhancement in this area. Tenosynovitis can be seen as a enhancement of the tenos tendon and sheath with signal changes within the tendon. Neuropathy can be seen as a altered signal within the nerve. So here you can say there is altered signal intensity. They may or may not show the enhancement on post-contrast images. Coming to the more important pathology which involve the bones and joints. So neuroarthropathy or Charcot joint is because of peripheral neuropathy. The presentation depends upon the stage of the neuroarthropathy, whether it's acute or chronic. Another important point to remember that they can be complicated by the infections or vice versa. Radiographs are not very sensitive in acute stage of neuroarthropathy. So what happens in acute Charcot? What are the MRI features? The MRI is the best to confirm the diagnosis in cases of suspected early Charcot. The important the imaging features of acute Charcot on MRI is the bone marrow edema, soft tissue edema, and then can be associated joint effusions. But the two features like bone marrow edema and soft tissue edema are the important features of acute Charcot. Here you can say the case of acute Charcot. This is T1 weighted images, T2 fat set images. Here you can say there is a signal alteration in the multiple bones of the midfoot with the edema in the bone as well as in the soft tissue. The MRI can also be useful in cases of these patients if they are responding to the offloading or not. If there is significant marrow edema present on follow-up of MRI, then people say that the offloading should continue. Here you can say there is a acute charcot arthropathy in the acute stage, and in case after offloading, you can say there is a complete resolution of the edema. However, in this case, still there is a, after offloading, this follow-up MRI still shows some edema in the bone as well as in the soft tissue. Chronic charcot, they typically shows the typical imaging features like the fragmentation, deformity. They can easily diagnose on MRI. Coming to the more important pathology, the osteomyelitis. As I said, that they can be compromised with because of the local soft tissue compromise, as well as the neuropathy. The common the cause is the ulcer. When there is an ulcer, and then adjacent bone can be secondarily infected, lead to the osteomyelitis. However, in some of the cases, if you can't see the ulceration, still the osteomyelitis can be possible. Plain radiograph is the poorly sensitive, and MRI remains the best modality. So what are the MR imaging features of osteomyelitis? They are the typical primary imaging features. Bone shows the T1 hypointensity and T2 hyperintensity, and they show enhancement. They can be associated secondary signs like ulcer or sinus, cellulitis, abscess, and other features. So see here, this is a typical case of osteomyelitis in the lateral malleolus. This is the T2 fat set. Cornal, this is T1, and these are the post-contrast enhanced images. Here you can say there is a typical edema, and there is a ulcer formation here. And on T1, it shows the T1 hypointensity. So T1 hypointensity and T2 hyperintensity, and they shows enhancement on post-contrast imaging. So if you see these imaging features with the adjacent ulcer and the collection, then most likely diagnosis of osteomyelitis is there. Another case of osteomyelitis in the calcaneum, again there is a large ulceration with the signal alteration in the posterior part of the calcaneum, T2 hyperintensity, T1 hypointensity, and typical enhancement. So again is a case of the osteomyelitis of calcaneum. The joint can be involved when there is osteomyelitis, so adjacent part of the bone, the joint can be involved. They may show the joint fusion with synovial enhancement. The important the issue comes when there is not a T1 hypointensity, and they just show T2 hyperintensity. So these are the patients here. You are not sure whether to make the osteomyelitis features of osteomyelitis or not. Another the issue comes when the osteomyelitis is there with the cases of charcot arthropathy. So sometimes there is an overlap of these imaging features. Here you can say this is T1 sagittal images. Here you can say this is a typical feature of the arthropathy, neuroarthropathy in the midfoot region. Again, there is a large ulceration and soft tissue inflammation. So here in this case, again, there is both the features of charcot arthropathy as well as osteomyelitis is there. So you need to be very, very careful to make the diagnosis of both the pathologies. Again, this is the case of overlapping charcot with osteomyelitis. Here you can typical charcot features in the midfoot, and then the soft tissue inflammation and the osteomyelitis of the metatarsal head. So these are the important things we have to see very carefully of both the features of charcot as well as osteomyelitis features. The ghost signs are another feature which can differentiate the charcot versus the osteomyelitis. That this is T1 weighted images here, and this is T2 weighted fat set image here. So what is ghost sign? That usually the bones are not very clearly defined on T1 weighted, but they are more defined in the T2 weighted images or post contrast images, and this is one of the features to suggest the osteomyelitis. So this is the typical table which shows the difference between the neuroarthropathy versus the osteomyelitis. So here again you can see this is location is important to differentiate the two pathology. And apart from that, the joints can may or may not involve in the osteomyelitis. However, in Charcot arthropathy, joints are usually involved. Other features like cortical restrictions can be seen in the osteomyelitis, and bone fragmentation and malalignment they can see in the chronic Charcot arthropathy. So there's, as we have seen, there can be overlapping features in the Charcot and osteomyelitis, and some of the patients you can't differentiate whether it's a osteomyelitis or Charcot arthropathy. So people have used that can advanced imaging like diffusion or perfusion imaging can help in these patients. So these are the advanced imaging which can be done, like diffusion weighted imaging, perfusion, and MR spectroscopy. People have used more of diffusion and perfusion. So in diffusion, what we have to take the diffusion weighted imaging, and then we have to put the ROI and take the value. So there has been some literatures also. This is the one of the paper which said that the ADC value with the role of diffusion weighted imaging are quite useful to differentiate Charcot arthropathy with the osteomyelitis. In perfusion weighted imaging, it provides the insight into the vascularity of the lesions, and we have to use the dynamic contrast enhanced sequence, and then we have to make the time intensity curve. The semi-quantitative parameters like wash-in rate, time to peak can be assessed. So this is the one of the case where the osteomyelitis, we can see there is a early wash-in in cases of osteomyelitis in comparison to the Charcot arthropathy. There is a slow increase the wash-in rate of the contrast. So people have used these sequences also to differentiate the osteomyelitis versus the Charcot arthropathy. We have also done one study here in our department. We use the diffusion weighted as well as the dynamic contrast enhanced MRI to differentiate diabetic osteomyelitis with Charcot arthropathy. And in our study, we found that the value of both the diffusion as well as perfusion imaging are quite good enough and can increase the efficacy of MRI to differentiate Charcot arthropathy versus diabetic osteomyelitis. So to conclude that the diabetic foot comprise various soft tissue pathology as well as bone pathology. Radiological imaging are very, very important, as we have seen that MRI is the best modality for diagnosis, as well as they can be useful for the management of these diabetic foot complications. As a radiologist, we should know the role of various imaging features of these pathologies and should not misdiagnose these pathologies. Advanced MR imaging can be helpful and can add in the value when we are doing it, and it can be useful in addition to the conventional MRI imaging. So these are the references, and I thank you for your patient listening.
Thank you very much for your very informative lecture, Professor Mahesh Prakash. For all the audience, should you have any questions, please write in the chat box and the speaker will answer your question. And now we come to the second speaker, Dr. Irma Darina Fitri. Her current position is musculoskeletal radiologist consultant, Saiful Anwar General Hospital, Malang, Indonesia. She will speak about differentiating TB spondylodiscitis from pyogenic and malignancies imaging feature. The time is yours now, please.
Hi, I'm Irma Darina Fitri from Malang, Indonesia. I will present about how to differentiate spinal TB from pyogenic and malignancies in imaging features. We know that vertebrae is the most common site of infection. It's about 2 until 7% of all cases of musculoskeletal infections. Vertebrae is the most common sites of metastasis to bone. About 30 until 70% of all cancer patients. It's important to differentiate spondylitis from metastasis because it's significant differences in the subsequent management. The most frequent spinal infection is tuberculosis and pyogenic spondylitis. Tuberculosis spondylitis is more common than pyogenic. It's about 30 until 40% versus 0.15 until 3% in osteomyelitis cases. This is a vertebral anatomy, which is a complex structure and be divided to 3 columns, anterior, middle, and posterior. Spondylitis is defined as infection by a specific organism which involves one or more components of the spine, including vertebrae, intervertebral disc, paraspinal soft tissue, and epidural cavity. There are many modalities to evaluate spinal infection and malignancy: conventional radiograph, CT scan, MR imaging with contrast enhanced, DSA, CTA, MRA, and bone scintigraphy. Spondylitis tuberculosa result from arterial hematogenous seeding of the Mycobacterium tuberculosis starting from a quiescent or active pulmonary focus or contagious or lymphatic spread from pleural disease. The 4 patterns of spinal involvement are peridiscal, central, anterior, and atypical. The most common form is peridiscal. The anterior aspect of the vertebral body adjacent to the subchondral plate is usually affected. Extend over multiple levels begin beneath the anterior longitudinal ligament. A clue to diagnosis in radiograph evaluation is the presence of extensive vertebral destruction out of proportion to the amount of pain. MR imaging is the imaging modality of choice for diagnosis of spinal TB. This table describes the correlation between severity, clinical radiological features, and duration of illness. We divide it in 5 stages, 1 until 5. Stage 1 in pre-destructive. We only see straightening of curvatures, spasm of perivertebral muscle. The CT scan would show hyperemia, and MR imaging shows about marrow edema. And this stage occurs less than 3 months. Stage 3 until 5 all have vertebral body destruction, collapse with kyphotic deformity of spinal curvature. Stage 5 occurs more than 2 years. The pathological spondylitis process in the end will cause bone destruction, vertebral collapse, which then continues to gibbous deformities, and if it continues, will invade surrounding structures forming an abscess granulation tissue, direct dural invasion accompanied by angulation. All of this will cause spinal cord compression in the severe states. Plain radiograph in AP and lateral position. We look Phoebe-like collapse of the vertebral body with preservation of the disc space and in plates of the vertebral above and below. This is part of chest radiograph. AP position show fusiform soft tissue swelling at lower thoracic region attributable to formation of tuberculous paraspinal abscess. CT scan play a role in divining the extent of bony destruction and plate destruction, fragmentation of the vertebrae, and paravertebral calcification. Paravertebral and or epidural abscess may show thin rim wall enhancement. CT-guided fine needle aspiration localization for biopsy diagnosis. MR imaging with contrast enhancement. In the earliest MR imaging finding, we can see end-plate edema characterized by reduced signal intensity on T1 weighted and high signal intensity on T2 weighted. STIR and T1 weighted fat saturated post-gadolinium image. Progressive bone necrosis can cause collapse and wedging until kyphotic and the characteristic gibbous deformity. Dissemination of infection to adjacent paraspinal soft tissue results in paravertebral abscess formation. This is T1 fat saturated MR gadolinium imaging through the cervical spine showing extensive bone destruction of contiguous vertebrae at C6, 7, and T1 levels with a large rim-enhancing prevertebral abscess extending inferiorly. This is coronal STIR MR images in different patients demonstrating bilateral psoas abscess. With T2 weighted STIR, we see about hyperintense lesion in the psoas projection, and the T1 fat set gadolinium image, we can see kystic lesion with rim enhancement, thin wall, and bilateral psoas. The lateral plane radiograph of the lumbar spine demonstrates irregular and sclerosis involving the anterior vertebral body of L5 in keeping with an indolent process. Note the vertebrae and plates are well defined throughout. In sagittal, T1 weighted and B and T2 weighted MR images showing prevertebral subligamentous abscess at lumbar 5 with vertebral body destruction but relative sparing of the disc. Okay, now we will learn to distinguish tuberculous spondylitis from pyogenic. This table is presenting about characteristic of TB spondylitis from pyogenic. History duration of illness in TB spondylitis occurs longer than pyogenic, maybe in months to years, whereas days to months in pyogenic. Based on the common location, TB spondylitis occurs more often in the thoracic spine and pyogenic in lumbar spine. About the number of vertebral involvement, disinvolvement, vertebral collapse, bone destruction, posterior element involvement, and paraspinal and epidural abscess will explain in next slide. Involvement of the corpus vertebrae, tuberculous spondylitis shows more than pyogenic. This is caused by presence of proteolytic enzyme in bacterial infection, will cause damage to vertebral disc and other parts of the vertebral. Such damage cause more severe clinical manifestation than tuberculous spondylitis. So, pyogenic spondylitis is often detected earlier with a fewer number of involved corpus vertebrae than tuberculous spondylitis. This involvement in tuberculous spondylitis shows less frequency and severity than pyogenic spondylitis. This is related to presence of proteolytic enzymes in bacterial infection bacterial infection. MR gadolinium image show the same characteristics as tuberculous spondylitis be detected in late stage with more vertebral collapse and bone destruction. Tuberculous spondylitis more often involves the posterior segment with paraspinal and epidural abscess than pyogenic. MR gadolinium image show that tuberculous spondylitis have regular and thin walls, whereas pyogenic with irregular, heterogeneous enhancement and thick wall paravertebral abscess. Next, we will learn to distinguish spondylitis from malignancy process. This table shows about the characteristic of infectious damage from malignancy and spondylitis. In the location, the space, vertebral end plate, vertebral head, part of vertebrae, enhancement pattern, paravertebral mass, and paravertebral abscess will explain in the next slide. MR images show that spondylitis more common be seen in lower thoracic or upper lumbar spine, whereas malignancy can be at any level. Spondylitis is more frequently cause decrease of disc space, irregularities of vertebral end plate, and often cause decreased vertebral height, whereas relative normal in malignancy process. MR gadolinium images of spondylitis show anterior involvement, which is more frequently than anterior-posterior in malignancy. MR gadolinium images show that spondylitis have rim enhancement with more kystic lesion than malignancy with heterogeneous bulging solid mass enhancement. Okay, for finally, thank you for your all attention.
Thank you very much for your excellent lecture, Dr. Irma. For all the audience, should you have any question, please write in the chat box and the speaker will answer your question. And now we come to the third speaker, Dr. Elisanti Dwi Marta Diani. Her present position is a lecturer, faculty of Medicine, Udayana University, musculoskeletal consultant, radiology department, Professor Dr. HCNC Ngurah Hospital, Denpasar, Bali. She will speak about imaging of musculoskeletal tuberculosis. The time is yours, please.
Musculoskeletal tuberculosis account approximately 10% of tuberculosis infection. The resultant bone and joint destruction is the cause of severe morbidity. The most common form of musculoskeletal tuberculosis is tuberculous spondylitis, which reaches almost 50% of the cases, and the remaining is extraspinal tuberculosis that can be manifest as peripheral arthritis, osteomyelitis, or soft tissue infection, including tenosynovitis, bursitis, or myositis. Intercurrent active pulmonary tuberculosis is only seen in about 50% of the patient. Tubercle bacilli on Ziehl-Neelsen or acid-fast staining will appear as long red rods structures like this, and on the side of infection, the bacilli will induce granulomatous inflammatory reaction. Host inflammatory response will result in liquefactive and caseous necrosis, tissue destruction, and abscess formation. The infective focus can be spread to adjacent tissue, and on later stages, calcification of the granulomatous lesion might be happen. Extraspinal musculoskeletal tuberculosis has several mechanisms of spreading. Hematogenous dissemination is the most common mechanism of spreading, and also lymphogenous spread from a primary or reactivated focus of infection. Direct inoculation of the organism into the site of infection can be one of the mechanisms of spreading as well, and injuries may result in reactivation of dormant infection. Now we move to tuberculous osteomyelitis. Tuberculous osteomyelitis usually hematogenous in origin. Metaphysis is the common site of infection. This because of the metaphysis has abundant slow flow vessel within the metaphysis. The metaphysis also has discontinuity on its endothelial lining. So the permeability of the vessel will be increased, and the tubercle bacilli can be moved easily from intravascular into the perivascular tissue. Tuberculous osteomyelitis commonly seen in bone of the extremities, including the small bones of the hands and feet. In long and tubular bones, it often involves the epiphysis. In children, metaphyseal foci can involve the growth plate, and this characteristic differentiates tuberculosis from pyogenic infection. In pyogenic infection, transvisial spreading is rare because of the growth plate act as a barrier that prevent extension of the metaphyseal infection into the epiphysis. But in tuberculous arthritis, transvisial spreading is quite often happen. Pathogenesis of tuberculous osteomyelitis. Tubercle bacilli form a granulomatous lesion at the site of infection. Liquefaction and caseous necrosis and then occur and followed by resorption of the bone trabeculae. If the lesion involves diaphysis, there will be cortical destruction and followed by periosteal reaction, also soft tissue collection. Cystic tuberculosis consists of well-defined metaphyseal area of hyperlucency with variable amount of sclerosis. In this picture, we can see that the lesion extends from the metaphysis into the physis and epiphysis. And this appearance is characteristic of tuberculous osteomyelitis. Dactylitis involves the short tubular bone of the hands and feet in children. The lesion demonstrates soft tissue swelling and periostitis, followed by gradual bone destruction and sometimes questrum formation. Expansion of the bone with cystic changes is known as spina ventosa. Now we move to tuberculous arthritis. Tuberculous arthritis may result from osteomyelitis lesion that erodes into the joint space or hematogenous dissemination through the subsynovial vessel or infected paraarticular soft tissue or transvisial spreading of tuberculous osteomyelitis. When we talk about tuberculous arthritis and pathogenesis, there are several pathways of the pathogenesis. The first is from periarticular tuberculous osteomyelitis. In this condition, tubercle granuloma causing local bone destruction, and then followed by reactive hyperemia that manifests as a marked juxta-articular bone demineralization. When the disease process reaches the subchondral region, the articular cartilage will lose its nutrition, and the articular cartilage can be detached from the bone, and loose bodies of cartilage will be developed within the joint. This is the pictures of rice bodies in tuberculous arthritis that manifest as multiple hypointense lesion within the joint effusion. And this is a rice body that appears on arthroscopic examination. The other path of pathogenesis of tuberculous arthritis is from tuberculous synovitis. Tubercle bacilli in subsynovial vessel will causing synovitis. On this condition, synovial membrane will be congested and thickened, and joint effusion can be developed. Granulomatous lesion and then expand over the bones at the synovial reflection and causing erosion and also cartilage destruction. With further disease progression, periarticular osteolytic bone lesion will be developed. Necrotic articular cartilage and accumulation of fibrinous material in the synovial fluid can produce the rice bodies. In tuberculous arthritis, we know about Phemister triad that consists of periarticular osteoporosis, peripheral osseous erosion, and gradual diminution of the joint space. One important thing that we should keep in mind that no single radiographic features that allow a specific radiologic diagnosis of tuberculous arthritis. This case show Phemister triad that manifests as peripheral bone erosion here, and then periarticular osteopenia and joint space narrowing. This case is about tuberculous arthritis of the right hip. Here we can see that the head of the femur has been dislocated superiorly, and then we can see also destruction of the right femoral head and also marked osteopenia juxta-articular and diminution of the joint space of the right hip. We can see also soft tissue swelling here surround the right hip and also calcification within the swollen soft tissue. And this characteristic is similar with tuberculous arthritis. When we confirm with chest radiograph, we can see that there are tuberculous process on right and left lung. Tuberculous arthritis of the knee, or we call gonitis, can give similar appearance. We can see here there are multiple sites of peripheral bone erosion and then periarticular osteopenia and diminution of the joint space. MRI on T1 weighted image with contrast administration show multi-site of synovial proliferation that causing erosion of the adjacent bone and show contrast enhancement after contrast administration. And this appearance is consistent with tuberculous arthritis. This case is about tuberculous arthritis of the midfoot. We can see here there are multiple sites of proliferation of synovium and also marrow changes in the adjacent bone that looks hypointense on T1 and become hyperintense on T2 fat set and show heterogeneous contrast enhancement of the synovial proliferation, also the adjacent bone. This case is tuberculous synovitis in 6 years old male child with HIV infection. From knee radiograph, we can see that the bones show no abnormality, but there is swelling of the right knee, and we suggest this is joint effusion. From ultrasound, we can see marked proliferation of the synovium and also fluid collection at the posterior joint space. And when we apply Doppler examination, we can see increased vascularization of the synovium. And this condition is consistent with synovitis. Tuberculous bursitis and tenosynovitis may result from hematogenous spread, although the primary bursitis due to hematogenous spread is rare. Tuberculous bursitis or tenosynovitis can be happen due to periarticular extension of tuberculous arthritis as well. Tuberculous bursitis initially develop as serous bursal effusion. If there infiltration of tendon or synovium, synovial thickening can be happen. Tubercle formation in the synovium can result in caseation, necrosis, and secondary effusion within the tendon sheath. If disease progression worsen, it may lead to thinning of the tendon and tendon rupture. This case is about tuberculous bursitis of the bursa surround the major trochanter of the left femur. We can see that there is fluid collection around the bursae and also debris within the fluid collection. The last one is tuberculous myositis. As we know that isolated skeletal muscle involvement of the tuberculous myositis is extremely rare. Skeletal muscle are considered to be forbidden tissue for growth and multiplication of tubercle bacilli. This because of the muscle has poor oxygen content with high lactic acid concentration and paucity of reticuloendothelial cells. Tuberculous myositis commonly happen as a result from disease progression and local spreading from adjacent tuberculous lymphadenitis, osteomyelitis, or arthritis. Direct inoculation through contaminated medical devices might be one of the port de entry of tuberculous myositis. The favorite track of tuberculous myositis is along the fascial plane. Why? Because the fascial plane is a route with least resistance. Tuberculous myositis manifestation may mimic malignant or other inflammatory disease, and it may lead to misdiagnosis of tuberculous myositis. This case is about tuberculous myositis of the vastus lateralis muscle. We can see that the vastus lateralis muscle show blurring of its muscle striation. Compared with vastus intermedius muscle that show normal muscle striation. And we can see also distension of the epimysium of the vastus lateralis muscle. And then the patient come again several days after the first examination. We can see that there is fluid collection surround the epimysium of the vastus lateralis muscle. And this confirmed with MRI of the thigh. We can see that there is fluid collection within the vastus lateralis muscle with fistula formation at adjacent soft tissues around the fluid collection. This case is about tuberculous arthritis, bursitis, and intramuscular abscess in one patient. Tuberculous arthritis in this case is manifest as a synovial proliferation in the shoulder joint, and we can see here and here, and show strong contrast enhancement after contrast administration. Tuberculous bursitis manifests in this case as fluid collection at the subdeltoid subacromial bursa that show rim contrast enhancement. And intramuscular abscess is seen within the deltoid muscle that manifests as a fluid collection. On T1, it shows hypointense and become hyperintense on T2 and show restriction of diffusion on DW image and ADC, and also reveal rim contrast enhancement after contrast administration. And take-home points of this talk are musculoskeletal tuberculosis is a great mimicker with several mechanisms of spreading. Manifestation of tuberculosis can be found in bone, joint, or soft tissue, and this is important to differentiate extraspinal tuberculosis infection from other pathology. Thank you for your kind attention.
Thank you very much for your very clear and informative lecture, Dr. Elisati. And for all the audience, should you have any question, please write in the chat box and the speaker will answer your question. And now we come to the last speaker. Last but not least, Dr. Perami18Sept22HallB. Currently, he is Associate Professor Dr. Perami18Sept22 Institute of Medical Sciences and Research Foundation, India. He will speak about pathological radiological discordant findings, an interesting case series where we did not anticipate the pathology by radiology features, but with surprising outcomes. The time is yours now, Dr. Felicity, please.
Very good morning, everyone. I am Dr. Perami18Sept22 from India. Today, I am going to talk about radiological pathological surprises. These are case-based review series where we could not anticipate the final histopathology from the radiology. Sometimes it was there in our differential diagnosis, sometimes even we could not anticipate it in the wide differential diagnosis also. We have compiled a small series, which I am going to show you, which are 6 in number, one after another, with complete clinical and histopathological data. Case number 1. 19-year-old male came with the chief complaint of the swelling and swelling in the left palm since 5 years. Very slow growth or no growth. 3 centimeter in clinical examination, smooth margins, soft, slightly tender, not freely movable, but moving with the flexion of the fingers. Clinician felt that it could be a neuroma, neurolipoma, and ganglion cyst because the wrist, near the wrist, the commonest benign lesion is ganglion since it is 5 years. Ultrasound has been performed as a part of the initial investigation. Before ultrasound, X-ray is done and it is showing slight calcifications within the lesion. Ultrasound reconfirmed the calcification and it is closely associated with median nerve. They felt it could be a fibrolipomatosis hematoma. We proceeded further to MRI. PD fat saturated sequence is revealing hyperintense lesion, but it is not that bright. In T2 weighted images, it is showing intermediate signal intensity, some dark areas within it. It could be more of fibrous type of material rather than mucinous type of material. There are multiple signal voids seen which are consistent with calcification, which we discussed earlier in ultrasound. After giving the contrast, this is intensely and homogeneously enhancing. T1 weighted axial, the median nerve got compressed and the lesion is T1 hyperintense compared to the muscle, but it is not that bright as fat. So in gradient, there is no further blooming except those 4 calcifications, so there is no hemorrhagic areas. And post contrast, it is showing intense enhancement and post contrast study, just like the previous slide showing. So still we consider lipohematoma because some T1 hyperintensity, though it doesn't have a classical morphology of the fibrolipohematoma. That is our thought, that this is not at all the classical textbook picture of lipohematoma. So because of the direct contact with the median nerve, we consider that one of the possibilities. Nerve sheath tumor is another possibility, but nerve sheath tumors hardly calcify, so we could not even confident about that diagnosis. Finally, GCT of tendon sheath, if it were to be GCT or pigmented villonodular synovitis, on gradient images, it would have been much more bloom, which is not our case. So we have no clue at this stage. Surgery has been performed. The tumor is easily resected. This is gross examination. This is from the tendons. It is easily separable from the flexor tendons. This is the anterior and posterior aspect of the tumor. And on microscopy in 4x, 10x, and 20x has been done, and it is showing various features which are suggestive of soft tissue lesion. Further, after the histopathology, we have done SMA, immunohistocytochemistry, and S100. SMA is strongly positive and S100 negative. With this biopsy and histopathology and IHC, together they concluded this to be a calcifying aponeurotic fibroma. So then when we went back to the literature, it is exactly correlating what has been described already in the various case reports. Calcifying aponeurotic fibroma, CAF. So that is our final diagnosis. So it is basically a benign tumor, commonly in the young adults, males, predominantly. Palm and hand are most common sites. Wherever there is aponeurosis and fascia, it can come. It not necessarily directly attached to aponeurosis. Even tendon sheath, it can get attached. Subcutaneous, usually painless. So young adult, if you see an intermediate signal intensity calcified intensely enhancing lesion, always suspect calcifying aponeurotic fibroma. That is take home for this. So case number 2. So this is 73-year-old female complaining of pain in the interscapular region, radiating to the upper limb. So there is some dorsal spine symptoms and myelopathy symptoms pertaining to the dorsal spine. That is the final neurological evaluation revealed. So they have advised for a dorsal spine MRI. Initially, we did plain study. Let me move this one. So there is extramedullary intradural elliptical lesion, which is T2 hypointense, which is causing displacement of the card anteriorly. We don't have any clue. I strongly believe that this could be hemorrhage because many times we see spontaneous epidural hemorrhages in patients, especially with bleeding diathesis and the patients who are taking on anticoagulants. So this T2 dark, impressive darkness is, I thought it is consistent with the possible hemorrhages. That is why thought process. T1 weighted also slightly hyperintense than usual. So that is further confirmed that this could be a hemorrhage. But after giving contrast, our thought is changed. There is intense homogeneous soft tissue enhanced type of enhancement is seen. Adjacent bones does not reveal any obvious signal changes or abnormal enhancement. So hemorrhage is out from our thought process, but everything fitting into the melanoma, or it can be heavily fibrosed or calcified meningioma. It can be epidural metastasis, sorry, it can be even lymphoma. So these are our differential diagnosis after doing post-contrast study homogeneous enhancement. Patient is continues to develop progressive neurological deficits, compressive myelopathy features. Then we went for surgery. Lesion is excised and sent for histopathological examination. HP is like this. It shows fibrocartilaginous, myelofibroblasts, inflammatory cells, plasma cells, lymphocytes in the myxoid background consistent with inflammatory pseudotumor or myofibroblastomas. This is a new name for the old inflammatory tumors, spinal inflammatory pseudotumor. All these come now IgG4 spectrum of disorders. These are commonly seen in the orbit, which we do imaging very quite often. Heart, gastrointestinal tract, liver, lungs, mesentery, and retroperitoneum, kidneys, urinary bladder, it can be seen. CNS involvement is rare, especially the main CNS, but Jura can get involved. And all these are linked nowadays. Around 20 sites are now reported as related to IgG4 related sclerosing disease. This doesn't have any specific radiological characteristic. Mostly by diagnosis of exclusion, you will get like these shocks. Myofibroblastic tumor was the earlier name. When preoperative MRI imaging reveals some soft tissue component without bony destruction and maintaining normal fatty marrow signals, then you should think of this one. In other disorders like earlier differential diagnosis, which thought lymphoma, myeloma, all those things, there will be some bony destruction and bone marrow signal changes would be apparent. Case number 3, sorry. 30 years old, presented with sacral pain since 3 months, subacute presentation. So this is young lady. There is a sacral tumor extending from the vertebral body across the spinal canal, involving the posterior properly arising even from the posterior extending anteriorly without obvious disc destruction. Impressively, there are multiple fluid levels. This is blocking completely the thecal sac. So multiple fluid levels with little bit soft tissue is seen in T2 weighted and star images. T1 weighted images, the tumor is appearing like possibly a lytic lesion with multiple hyperintense areas. So when you see in the bone such an impressive fluid levels, especially posterior involvement, we would think of aneurysmal bone cyst. But patient is little bit elderly. Even GCT we thought could be possible because they sometimes show these fluid levels. A combination of GCT and ABC is also a possible thought. Then these are the lines we thought of actually. Axial, it is showing hyperintensity, isointensity, and there is some fibrous elements or a blood element like thing is seen, sediment here, multiple fluid levels in the coronal star images. So our radiological diagnosis predominantly of GCT and ABC. But to our surprise, the pathology came slightly different. They have taken a big chunk of tissue for biopsy and partly curettage type of treatment. Microscopically, they revealed spindle cell tumors, which is actually a morphological diagnosis, but it shows malignant properties. Some tumor osteoid also they observed. So initially they thought of osteosarcoma and spindle cell sarcoma. We sent for second opinion. They told that it's destroyed bone rather than tumor osteoid. So it is most likely compatible with the spindle cell sarcoma. So spindle cell sarcomas, basically, it is more of a morphological definition by pathologists. It can be dermatofibrosarcoma, fibrosarcoma, synovial sarcoma. It can come into various histopathologies finally after immunohistocytochemistry. So when the patient, when the histopathologist treats it as a malignant tumor and showing spindle cells, it can be spindle cell sarcoma, which can come in the bone and soft tissues. Final histopathology depends on immunocytohistochemistry. We ordered for that. We are actually, patient is not willing for further investigation. So that has been treated as a spinal cell sarcoma. So the lesions with the fluid levels need to be identified in the musculoskeletal system. One is aneurysmal bone cyst, that is far more common compared to the others, but keep in mind that there are so many other tumors can produce. The telangiectatic osteosarcoma is one of the popular tumor which can produce fluid levels, hemorrhagic levels, just like our sarcoma, that is bone sarcoma. And we have recently seen a subcutaneous air fluid levels without significant even history of trauma, which finally turned out to be myositis ossificans. So there is a long list of 10 conditions where you will find multiple fluid levels that all need to be kept in mind while diagnosing or formulating the differential diagnosis of bone lesion and soft tissue lesion. Case number 4. This is relatively straightforward case. We, certain extent, we anticipated the diagnosis before, but interesting to show I shared. 14 years old girl presented with right side chest pain, shortness of breath since 3 months, dry cough, fever occasionally. So they taken a chest X-ray in the peripheral center. They started AITD a week, but they referred somehow to us later. What we found is extraparenchymal pleural based or chest wall based mass lesion, lobulated, where the asterisk and arrow is showing, with the side pleural effusion, which is creeping along the lateral chest wall and blunting of the right CP angle. So further, we have taken a chest, then we saw flow picking up a solid lesion associated with the pleural effusion and collapsed lung. So this we thought need to be further investigated by CT scan. So CT scan shows heterogeneous necrotic mass lesion, which is in direct contact with one of the rib. Rib is granulated, not completely destroyed, but some altered in pattern, and the mass is directly looking like burrowing into the chest wall associated with significant pleural effusion and mediastinal shift. So this we thought we might be dealing with some small round cell tumor considering the age. And we just taken some sections of MRI which beautifully differentiated collapsed lung. The plain MRI itself is showing tumor beautifully this surrounded by malignant effusion and passive collapse. So what are the possibilities? If it is a bone lesion or soft tissue lesion, we might be dealing with Ewing sarcoma, lymphoma, leukemia. But if child is 14, still rhabdomyosarcoma is a possibility. It can be a metastasis from the neuroblastoma, pleural-based lesion like mesothelioma, which is rare at this stage. Finally, we gave more yield towards to Ewing sarcoma. That is our leading possibility in the report. So FNSC itself is revealed multiple small round blue cells would contain majority of the cell contains the nucleus, which is blue in color, shown as a yellow arrow, and this is a small round blue cell tumor. This is the RBC in the background. This is given radiological picture. They are strongly suggested Ewing sarcoma. Later, patient went to see any other spread to the other part of the body. Bone scan did not reveal any other focus, and biopsy done later, which is also revealed final diagnosis with immunocytohistochemistry and all other tests as a Ewing sarcoma. These are family small round blue cell tumor. There are 5-6 in this group. All shows Homer rosette and other shades of small blue round cell in the microscopy. This is not the final biopsy picture. This is just a Google slide graphic. So this is final diagnosis: primary Ewing sarcoma presenting as extraparenchymal chest mass with rib lesion. This is not uncommon, but only 6% of the Ewing sarcomas comes from the chest. Remaining would be coming from the long bones like diaphyseal lesions. Next case number 5. This patient is a little bit tricky. There is a pain since a few months in the tibia. We have taken X-ray, relatively well-defined or ill-defined borders. Central part is showing lytic area associated with significant sclerosis. We all had a doubt whether this is a chondrite matrix or any new bone formation more of chondrite matrix. So this we went for further investigation by MRI. So MRI is showing a very relatively well-defined lesion in the anterior part, which contains some fat signals, some fibrosis, some sclerosis, some cyst. So we considered these fat signals are native distorted fat by the lesion because they all got suppressed in fat saturated sequences. So that is our thought process, that fat is actually not part of the tumor, which is residual marrow or distorted marrow due to the infiltration of the tumor. Tumor contains multiple cysts, and this contains cyst solid areas as well as some fatty signals on these T2 weighted images. At this stage, we have three differentials in the mind. It could be ABC, which is not completely fitting it, cartilaginous tumor, or a hydatid cyst, which are not uncommon in our regions within the long bones. These are our thought process. One of the things is we could have seen this fat as a tumoral fat. We consider that as a mara fat in the initial thought process. So this is PD, where the PD fat sat, where the majority of the tumor is suppressed except the cystic components. And T2 is showing both cyst and lipomatous components together. So we have taken a CT scan. CT scan, if you keenly observe, there are some areas which are cysts, actually 3-ounce field unit. If you take the density at some regions, they are actually in the minus, which are suggestive of lipomatous tissue. So we thought that could be native, but this is very well-defined sclerotic lesions with extensive internal coccyidea type of sclerotic lobulated stellate pattern. So a combination of sclerosis and fat and cyst should suggest the possibility of final diagnosis, which we could not confidently anticipate, that is intraosseous lipoma. So even the pathologist read this fat as a physiological marrow, which has been taken along with the scooping or evacuation of the tumor while grafting. This has been evacuated. But careful surgeon, radiologist, and pathologist together discussed that this is a tumoral fat, not the normal fat that is looking slightly different from the routine fat. And the final diagnosis is intraosseous lipoma. This is the stage. Stage 3 of lipoma contains often a sclerotic material, just like the CT scan. Fatty material and cyst within them should be anticipated whenever you get in the classical sites. So after the calcaneum, this is one of the sites, though intramedullary lipoma by itself is not that common. The last case, this is a sports person or university person coming from the US, was playing a football, and there is some blister-like lesion in the anterior part. This is immediately presented after the trauma. They thought this could be any subperiosteal hematoma causing burrowing. This one, give us some time, let us see what it happens, because this is immediately after the football hit. There is subtle sclerosis in the medulla. So then it came for, since it is post-trauma, everything is initially thought process is like that. But there is a sclerosis, there is irregularity, there is a periosteal or cortical thickening, and there is a scalloped border, which is very less likely to caused by acute trauma. So all these made suspicious to us, and we have taken, let me move this one. Okay, there is a tumor is actually on the surface of the cortex. There is soft tissue component. This soft tissue component is hyperintense, which is burrowing actually into the cortex. This is showing some sort of cartilaginous signals. So we thought like this could be a periosteal tumor, periosteal osteosarcoma, and this could be chondroblastic periosteal osteosarcoma, as it is causing surface blistering and erosion. And the same picture, the medulla is also not looking that healthy. There is some medullary sclerosis, soft tissue swelling, surface lesions, osteosarcoma type of appearance, surface juxtacortical or surface or periosteal osteosarcoma. That is our leading possibility. PET examination did not reveal any abnormality. Marrow examination has been done from the other sites, which is also did not reveal any obvious abnormality. So PET, there is no other focus. Marrow exam is also showing normal pattern. So we thought it is osteosarcoma, which did not spread to another areas. So this is my diagnosis, chondroblastic osteosarcoma, though initial radiologist reported that as a osteomyelitis. Then we thought what to do next after this chondroblastic. So then we went through series of immunocytohistochemistry, and we run all this one. Finally, the final diagnosis is diffuse large cell lymphoma. So the radiologist felt like me, I felt like a periosteal more chondroblastic osteosarcoma, but they reported as osteosarcoma, but more of conventional type. But immunocytochemistry of multiple things has finally confirmed that we are dealing with diffuse large cell lymphoma. So this might be interesting, this one, but we should not stop investigating at the level of first opinion or second opinion of pathologist from one place to another. So this patient has got treated further and finally became normal. The X-ray becoming almost returned to the normal in the second and third follow-up. Repeated biopsy also did not reveal any abnormality in the rest of the bone marrow, confirming that this is primary intramedullary lipoma. These are my acknowledgements from the various departments. And thank you very much for giving me this opportunity to Asian Musculoskeletal Society, and I'm part of the Indian Musculoskeletal Society, and for the guests or invitees are in Indonesian Musculoskeletal Radiological Society. So this is my college where I collected majority of the slides and cases. Thank you very much. Have a good day.
Thank you very much for your excellent lecture, Dr. Belisetti. For all the audience, should you have any question, please write in the chat box and the speaker will answer your question. We have now reached the end of this session. Thank you for your participation. Dr. Paulus Raharjo will close the AMS annual scientific meeting, and I'm Sri Andriani will signing off. Have a good day, everyone.
Dear colleagues, we are at the ending of the first half of the combined meeting, which is the AMS Annual Scientific Meeting. The Indonesian MSK Radiology Society meeting will be held next week. And on behalf of the President of AMS, Professor Tamotsu Kamishima, and the AMS Executive Committee, I would like to offer our greatest appreciation, especially first for the 41 speakers from AMS, and secondly to the organizing committee chaired by Dr. Elisanti Dwi Martadiani. We will see each other again in the next AMS annual scientific meeting in Hainan, China in September 2023. Please monitor for the exact date through the AMS website. The AMS speakers are free to attend the Indonesian Musculoskeletal Radiology Society meeting, the 23 to 24th of September. However, most of the presentation will be in Indonesian with English PowerPoints. Speaker certificate will be sent on Tuesday, the September 20, 2020. We apologize for any inconvenience. See you in Hainan, China. And I would like to give the honor of to Dr. Elisante Dwi Martadiani to announce housekeeping messages. Thank you.
Thank you, Dr. Paulus Raharjo. We have now reached the end of AMS Annual Scientific Meeting session. Thank you for your participation. And please join us next weekend for 10th Annual Scientific Meeting of Indonesian Musculoskeletal Radiology Society. We remind you that the website will stay open until 17 October 2022. You can access on-demand recording of the lectures until that time. We also invite you to visit our sponsor booth in the exhibition hall and e-poster exhibition. Thank you very much for your attention. See you next week.